Hi, I'm Dr. Promise Olomo, Certified Registered Nurse Anesthetist. Today, I'll be presenting a tutorial on endotracheal intubation. The audience for today's tutorial are beginners in the skills of endotracheal intubation, such as anesthesia students, respiratory therapists, or EMT personnel. The setting for today's tutorial will be an operating room or a controlled environment for intubation. The objective for today's tutorial are that learners will be able to list the components of endotracheal intubation. Additionally, learners will be able to describe the process of endotracheal intubation. We begin. The components of endotracheal intubation are preparation, positioning, pre-oxygenation, intubation, and confirmation of intubation. I repeat again: preparation, positioning of the patient, pre-oxygenation of the patient, intubation of the patient, and confirmation of the endotracheal tube. First, in preparation, we have all the equipment we need is what we prepare with. We have the endotracheal tube here. This is a 7/0 tube with a syringe connected to it and stylet, and it also has a bulb at the end that will be inflated once the tube is in place. We have a Mark III blade here with a light source that helps us see inside the glottic opening. We have our medications here, which we will mention: some tape, Tegaderm for the eyes, some lubrication for the eyes. We have our circuit here connected to an oxygen source. We have a mask, Untitled CO2 monitoring, a bag mask, an IV setup, and we have a stethoscope and some gloves at the end. So, we continue. Once we have our preparation done, the next thing is we go ahead and have our patient positioned. So patient positioning requires that the head of the patient be placed approximately at the xiphoid process. In addition to that height, we also try to have the patient's head turned backwards. Turning it backwards puts it in a sniffing position, which helps align three axes: oropharyngeal, pharyngeal, and laryngeal axis. As you would see here, the glottic opening is here at C6. So in order to place the tube successfully and have a line of sight or direct vision, those axes needs to be aligned. And the way to do that is to ensure that the sternum of the patient is leveled with the tragus of the ear while the patient's head is at the xiphoid process. That's that for positioning. Next thing, we pre-oxygenate. We turn our oxygen up to high flows for about 10 liters or more, and then we place the mask on the patient and we help support from under the jaw. Patient may make respiratory efforts at the beginning, but as we begin to put medications in the patient's IV and they begin to drift off to sleep, we will support by squeezing the bag and helping to pre-oxygenate, at the same time getting rid of nitrogen, which is about 78% of air mixture. Once we've done that and patient is unconscious, we go ahead and apply either our tape at the start of our pre-oxygenation to prevent abrasion of the corneal. We can put some lubricant or use the Tegaderm. We check for lash reflexes. Once there's no lash reflexes, that tells us that right here is an intubating condition. Then we give our rocuronium or succinylcholine muscle relaxant and wait either till we see fasciculations or we wait for 90 seconds for the drugs to actually kick in appropriately. Once that's done, we get ready to intubate. We go ahead and take out our endotracheal tube. We scissor the patient's mouth on the side, on the right side. So we scissor using our finger, which opens up the patient's mouth. With our laryngoscopy blade, we go ahead and we sweep the tongue to the side using our left hand, scissors with the right hand, tongue is swept with the left hand, and then we place the endotracheal tube with our right hand into the patient's mouth. And once we do that, the tube will come this way we'll see a glottic opening and vallecula. We'll lift it up and we place the tube in there. Once we do that, we'll go ahead and inflate, which suspends the endotracheal tube below the glottic opening. And then we tape the end of the tube to the patient's mouth. And that's the intubation process. We'll go ahead and watch a video now that will further show how this happens in a mannequin.
With the left hand, insert the curved blade of the laryngoscope into the mouth over the right side of the tongue, displacing it to the left and upwards. Advance the laryngoscope slightly until the tip of the epiglottis can be seen posterior to the back of the tongue. Advance the tip of the laryngoscope blade into the vallecula between the epiglottis and the tongue. With the handle of the laryngoscope pointing away from you at 45 degrees, lift upwards and away to lift up the tongue and epiglottis to display the vocal cords and the laryngeal opening. With the right hand, insert the endotracheal tube from the right-hand side of the mouth directly between the cords and into the trachea until the cuff passes through the cords. The markings on the tube at the incisors will show between 21 and 24 centimeters in the average-sized adult when the tube is in position. Remove the laryngoscope and inflate the cuff with approximately 15 mL of air to prevent air leaking during ventilation. Attach the tube to the bag and valve apparatus and ventilate the patient with the oxygen flow on 12 to 15 liters per minute. Confirm the position of the tube by auscultating over the apices of the lungs, the axillae and the stomach. If it is not in the correct position,
So once you've seen in the video the process for endotracheal intubation and all the personal protections that I employed in the process of endotracheal intubation. Now we go ahead and confirm the location of our endotracheal tube, which is usually approximately 3 times the length of the tube. So for a 7/0 tube, we expect it to be somewhere between 21 and 24 at the lips. Our end tidal monitoring helps us confirm, in addition to condensation in our mask, and then we listen for breath sounds as depicted in the video, and we try to ensure we can hear it bilaterally, both on the right and on the left side. In which case, once we confirm that the tube is taped in place along the patient's mouth, and then we turn on the ventilator, or we continue to hand mask and ventilate the patient. This concludes the steps for endotracheal intubation and the tutorial on the process. Any questions?
Yes, I do have a question.
All right, go ahead.
What do you do if you go to intubate but cannot see the glottic opening?
Excellent question. This commonly happens, and in this situation, you do one of 3 things. You ensure that the positioning is correct, meaning the patient's head is at the xiphoid process. You can further sniff your patient's neck backwards to ensure that you can align the 3 axes that we mentioned prior. Once you do that, you ensure that you either lift a little bit further to reveal the glottic opening by lifting in the vallecula. All those steps and changes should help you see the glottic opening. If after doing those changes you still do not see the glottic opening, you may be able to put your finger outside, 2 fingers, or if you have someone assisting you, to help drop the glottic opening by depressing at C6 here. It's possible that the patient has what is called an anterior airway, and after confirming positioning, sweeping better, lifting further, you may be able to depress the glottic opening, which will bring it into view. If after doing that, all of that still fails, then you can take out the endotracheal, the blade, and go ahead and mask ventilate. You may need an adjunct airway device, such as fiber optic intubation, or you may have to go for what's called a glide scope. I hope that answers your question.
Yes, thank you.
Thank you very much. This concludes this tutorial. Thank you for watching. Bye bye.